Dr. Joseph Chernecki is a professor of rehabilitative medicine at the University of Washington School of Medicine, and he's co-director of the Preservation Amputation Care Team. Dr. Chernecki is Associate Director of the Veterans Administration Research Center of Excellence, Limb Loss Prevention and Prosthetic Engineering Program of the Veterans Administration Puget Sound Healthcare System here in Seattle. His interests include gait analysis, how we walk, rehabilitation of amputees, biomechanical effects of lower extremity prosthetics, and electrodiagnosis. His interests further include the biomechanics of human motion, the economy of human ambulation, prosthetic biomechanics, and evaluation treatment of pain as a secondary disability after amputation. He's involved in graduate student education in mechanical engineering, in bioengineering prosthetics, and he teaches amputation rehab for resident physicians in physical and rehabilitative medicine. Dr. Chernecki earned his Bachelor of Science degree and his medical degree at the University of British Columbia, and he earned his Master's of Science degree and completed both his research fellowship and residency in rehabilitative medicine at the University of Washington.
Well, great. Thank you all for being here this evening. It's a pleasure to be here. Well, it was a real challenge trying to fit the rehabilitation of the amputee into sort of a 20, 25 minute, I may actually encroach on 30-minute presentation, but hopefully through this presentation you'll get a flavor for some of the issues that we deal with and basically how we do with our rehabilitation process. So why don't we go ahead and begin. You know, as Doug mentioned, this is probably, there's been no greater time in history when we've seen a lot in the lay press, on television, in magazines, about the capacities that amputees have and the accomplishments that they can make. Doug used the example of some of our returning combat injured who have run with the president, made, you know, the cover of magazines. There have also been a couple of amputees that have actually climbed Mount Everest. Mark Inglis, who was a bilateral below-the-knee amputee. Certainly a major accomplishment for anybody, and an absolutely massive accomplishment for somebody who is a bilateral below-the-knee amputee. Sarah Reinertsen competes in Ironman. And we now have sprinters in the Paralympics who are unilateral below-the-knee amputees or transtibial amputees that can run 100 meters in a little around 11 and a half seconds. So absolutely incredible people. And what I'd like to do is through this to kind of, you know, see whether or not how representative this is of the amputee population as a whole. I'm going to begin my presentation talking a little bit about some of the epidemiology of amputation. Doug kind of introduced a lot of the reasons that people experience amputation. I'll go into that in a little bit more detail. Ultimately, where I'd like to go is through the rehabilitation process, and then finally, I'd like to focus on the dysvascular, the elderly diabetic amputee as a unique population. It's the most prevalent population. So how many amputees are there in the United States? I think a lot of people would be surprised by this. It's not often that you sort of, well, you're in the grocery store or at the beach or at the park, see somebody who's an amputee, although that is becoming much more common, certainly. It's interesting, Doug talked about some of the changes in attitudes towards prosthetics. Historically, amputees wanted their prosthetic limbs to be absolutely cosmetic. Cosmetic to the extent that the limbs were airbrushed with vein patterns. They were actually, hairs were sort of introduced and pulled through some of the cosmetic cover to give the impression of hairy extremity if you were a male. These days, there's been a major change, and I think it's part of our sort of technologic society where people don't want cosmetic covers. They want to show some of the high technology. So it's a very interesting phenomena. Each year, there are about 150,000 new amputations that are performed in this country, and approximately 110,000 of those will be major amputations. That is an amputation above the level of the ankle. Over 90% of them involve the lower extremity. So what are the causes of amputation? As Doug mentioned, diabetes and peripheral vascular disease is the most common cause of amputation. Civilian trauma is another important cause of amputation. Military trauma, as you've heard, is sort of obviously an issue that is in all of our minds these days as our soldiers are returning from combat in Iraq and Afghanistan. Tumor and congenital amputations are way, way down on the list in terms of their relative prevalence. It's interesting, when you look at amputation in a more global perspective, what you see is that the patterns of amputation and the relative frequencies change depending upon where you live. In North America, and probably partly because of our diet and our relative sort of inactivity as a population, over 90% of the amputations are related to peripheral vascular disease and diabetes. Whereas if you look at more sort of third world, second world countries, 50% of the amputations will be because of trauma. So you have to sort of consider this on a more global perspective as well. So let's talk a little bit about some of the challenges that different populations face and challenges that we face as a rehabilitation team. First of all, in civilian trauma, obviously this is going to be a younger population. In North America, motor vehicle trauma is probably the most common cause of traumatic lower extremity amputation. Usually, although you can have multiple trauma, that is in motor vehicle accidents, you can have comorbid conditions such as traumatic brain injury or multiple musculoskeletal fracture in addition to the amputation. In civilian trauma, it's much more common to have an isolated amputation. The challenges of the younger individual, of course, is that when you're young, you have very high mobility demands, and especially in contemporary society, there is a desire to try to return to your high level of function. So they have higher mobility and recreational goals. They want to be able to get back, rejoin their lives, and do the things that they had always done. In addition to that, when you're young, obviously, many people are in the midst of the pursuit of their education. Sometimes, because of their amputation, they have to redirect their educational goals to make it more compatible with their life as an amputee. And certainly for people that are engaged in vocation, in a certain job, they may require some retraining, restructuring, depending upon the demands of their current vocation. Obviously, when you're in your 20s, your whole sort of psychosocial situation is different than when you're in middle age and when you're older. And obviously, the potential impact of an amputation on psychosocial dynamics, future marital relationships, these sorts of things are something that we all need to consider. Now, what about in the context of military trauma? Certainly, historically, this has been a young population. It's interesting, in Iraq, part of our combat soldiers are from the reserves, which tends to be a little bit of an older population. Actually, what we're seeing is that although on the younger side, there is some mixed age group in that population. I'm sure, as all of you notice in the press, that the IED, the improvised explosive device, is one of the common means of injury, which creates a blast trauma, which creates a unique pattern and distribution of injury that is unlike civilian trauma most typically. Here, in combination with the blast trauma and the use of body armor, the limbs are exposed and the limbs undergo severe trauma. So oftentimes these amputees will have multiple limb trauma. Their residual limbs will also tend to be more complex. Not universally so, but as a population tend to be more complex than civilian trauma. So as an example, in this individual, what you see is that there's sort of a complex soft tissue reconstruction that needs to take place with split thickness skin graft, which creates a complexity in achieving a comfortable and enduring prosthetic fit. The other sort of hallmark aspect of some of the amputation residual limbs with the combat population is something that's called heterotopic ossification. So this is actually ossification in the soft tissues, which normally doesn't take place after amputation. This ossification introduces complexities in once again obtaining a comfortable prosthetic socket fit. In this situation, you actually see a relatively sharp bony spicule that is extending down beyond the cut end of the tibia, and obviously when you're trying to load this within a prosthetic device to try to create a comfortable socket fit is really a challenge. In addition to the extremity injuries, traumatic brain injury is a hallmark of the pattern of injury with the improvised explosive device, and a full 60% of people that have been exposed to a blast injury will have a traumatic brain injury. So relearning how to use a prosthetic limb in the context of brain injury is really a challenge. And then finally, of course, obviously the mental health issues associated with combat are really a challenge. So the combat injured population obviously have a whole different spectrum of complexity. The psychosocial aspects of returning to civilian life and readjustment are really a challenge as well. Now, in the diabetic dysvascular population, typically this is an older population with a mean age of around 67 years of age. Now, this population also has multi-system disease. This is all multi-system medical disease, which introduces its complexities. So the challenges, a population who's aging, their ability to adapt and have systems in place to compensate for the amputation are diminished, and obviously their underlying medical problems introduce their own constellation of challenges. And then finally, although this population isn't trying to return to sport or high level of function, the risks of failure of rehabilitation are such that they lose independence and they lose mobility. So the risks are relatively high if we're not successful in the rehabilitation process. So as I mentioned, what I'm going to do is to focus on the diabetic dysvascular amputee. We talked a little bit, as I kind of in passing mentioned some of the challenges of the population, but I'd like to just describe in more detail some of those challenges from a medical perspective. I think a lot of us who are unfamiliar with the long-term sequelae of diabetes kind of view diabetes as sort of a nuisance. It's a hassle. You have to give yourself insulin, sometimes give yourself insulin multiple times per day. But over many, many years, there are some significant medical long-term sequelae. First of all, there's a greater preponderance of stroke. And stroke obviously can lead to cognitive impairments, perceptual impairments, language impairments, and motor control impairments, which can affect your probability of returning to successful prosthetic use after amputation. There's also diabetic retinopathy. We know that people that have compromised peripheral nerve function and compromised balance and stability use visual writing in space as an important adaptive tool. And when you have your eyes impaired by a retinopathy, it's an additional compromise. People with diabetes have a greater incidence of circulatory problems, atherosclerotic cardiovascular disease, so ischemic heart disease, and problems with pump function from the myocardium. Renal dysfunction, renal failure. Your kidneys are very important for maintenance of fluid balance, electrolyte balance, and you can imagine that if you have a residual limb, which is the alternative word for stump, residual limb is kind of the currently appropriate term for what is left after an amputation, so I won't call it stump. So you can imagine a residual limb that now has fluid volume challenges, and here you have to fit this thing inside a prosthetic socket. And the challenges of volume regulation are really important and can create some significant challenge in outcome. People with diabetes have peripheral neuropathy, so impaired sensation in their feet, which impair their balance and stability. They also have peripheral vascular disease, which can impair the circulation to the remaining limb. So diabetes definitely introduces a constellation of challenges that sort of challenge the whole team as we try to get somebody to their optimum level of function. As Doug mentioned, the amputee rehabilitation is multidisciplinary. It involves surgical team, rehabilitation physicians, nurses, therapists, social workers. It requires a team to really manage and optimize the outcome of the patient. What I'd like to do now is to kind of, in general terms, talk about rehabilitation and sort of approach it from a conceptual basis. What you see here on your left-hand side is on the y-axis here is the functional status of an individual. As each of us go through our lives, we have a certain function. We have, cognitive demands with our work. We have physical demands with our recreation and the work that we do. And together, they comprise the net sort of balance of what our functional status is at any given point in time. On the x-axis, we have time, so the passage of time throughout our lifespan. So what we see is that most people kind of function through life at a certain level, and obviously there will be undulations and fluctuations in where that is. But at the onset of any significant injury, whether that be stroke, spinal cord injury, brain injury, or amputation, there is a marked decline in function. And as part of the rehabilitation process, we will try to enhance the level of recovery and obviously try to get somebody to a maximum level of function. So in conceptual and visual terms, this is the rehabilitation process. So the idea is that we try to minimize the functional decline associated with illness or injury, prevent additional disability, shorten the time course of recovery, increase the functional outcome, and then to try to preserve that level of function throughout the lifespan. In the context of the amputee, this is what we see, the onset of some injury, whether it be a traumatic injury or, in the case of diabetes, injury to the extremity. There's a decision to amputate that's made, a decline in function, and ultimately recovery, prosthetic fitting, and maintenance of function. What I'd like to go through now is just to kind of describe what are some of the key issues that we face in the rehabilitation of somebody who is older, has diabetes and peripheral vascular disease. And what I'll do is start with the onset of injury and kind of go through the process. I don't know how many of you are familiar with why it is that people with amputation or people with diabetes end up with amputation. The most common factors that contribute to that are the peripheral neuropathy in accompaniment with poor circulation in the extremities. In this picture right here, you see the foot of somebody who has a peripheral neuropathy with weakness of some of what we call the intrinsic muscles of the foot, which creates an overpull of the toe muscles that lift your toes up, and also the long muscles that actually curl your toes down. It's called a claw-toe deformity. Now, you'd say, well, gee, so what's the big deal? You've got this claw-toe deformity, and maybe it's not pretty, but, it's okay. But in reality, what happens, you can imagine trying to fit this foot within the toe box of a typical shoe. This is going to be a problem. And what you see here is that there are signs of chronic sort of low-grade mechanical injury to the tops of the toes because they bump up against the undersurface of the shoe. In addition, because of the prominence of the bones here, the metatarsal heads underneath, you're at risk for the development of pressure injury on the sole of the foot as well, especially with a peripheral neuropathy where you don't feel abnormal pressures, and you can develop an ulceration without even knowing it. Now you have an ulceration, you don't have adequate perfusion to heal the ulceration, you have an ingress of bacteria, and in diabetes you don't often have the ability to deal with infection terribly well. So this is the most common cascade that leads to amputation in somebody with diabetes. Peripheral vascular disease can also in itself lead to amputation because of ischemia, poor circulation, and gangrene of the foot. So now you have somebody who has developed an ulceration, and you can say, so what's an ulceration? It's an annoyance, you have to change dressings on your foot, and yes, there's a certain sort of fuss factor that goes along with that. Now, if we look at actual studies that have been done to try to assess what the impact of diabetes itself is, and then the impact of diabetes with an ulceration on the foot, what we see is that on standardized health-related quality of life measures, people with diabetes have a reduced quality of life relative to an age-matched non-diabetic population. Now, if you add ulceration onto that, you have a further reduction in physical role, physical functioning, and mobility relative to the non-diabetic population. And you also have increases in anxiety and depression measures. So ulceration by itself results in a significant decline in function. Now, from a rehab perspective, one of the challenges that we face in the older population is that one of the standard treatments for managing ulceration of the foot is that you're told to stay off your feet, because we know that pressure it delays healing, and it can actually exacerbate ulceration. Now, one of the problems of staying off your feet, especially if you're an older individual, is that your muscles undergo deconditioning and atrophy. You end up with a reduction in cardiopulmonary function. And there are sort of this whole cascade of secondary deteriorating effects. This is now, before you've even undergone amputation, you're having a decline in your function. So one of the key aspects of rehabilitation at this phase is to try to find ways to enhance and maintain mobility, to provide adaptive equipment so that people can stay up on their feet without weight bearing through their foot with an ulceration, adaptive footwear, and to provide social and other support systems to enable them to function independently. Now, Doug talked a little bit about this whole problem of decision to amputate and the challenges that we face as a team with amputation decision making. And I'd just like to explore that a little bit further and maybe a little bit more from a rehab perspective. Here, what you can see listed, and I won't go through it all because we've already discussed this, some of the issues that people with diabetes face in terms of their comorbid medical conditions. Amputation decision-making is a team decision. So we have a surgeon who's interested in the viability of the limb, where will it heal, what are the surgical issues surrounding this decision to amputate. From a rehab perspective, what we're concerned with is how will that patient function with any given level of amputation. What we have to do is to put together that patient's sort of the critical evaluation of the patient and that patient's profile to determine how that unique individual might function with an amputation at each level. And ultimately, the patient is obviously a critical part of the team because they're going to have to weigh this input and make a decision in conjunction with the surgeon. Now, when I use the term here surgeon, that's surgeon at large. Somebody like Doug, who's obviously dealt intensively with amputees and has also dealt with the rehabilitation phases, not just the surgical phase, he can kind of substitute for the rehab doc here as well. He can do it all. One-man show. So what we're talking about here is balancing the risks of successful healing versus optimum functional outcome. One of the tools that surgeons have to try to help them is to try to understand how good the circulation is as you go up and down the limb. There's a tool called TCPO2 where you can measure the oxygen that is transpired through the skin from the blood vessels below to get an idea of how well that limb is perfused. And it is a helpful tool, although it's an imperfect tool. Surgeon experience is really the critical element here. From a rehab perspective, once again, we don't have great tools, but the elements that we use in our evaluation to help us make a decision include defining that patient's premorbid functional status, their comorbid medical conditions, cognitive function, motor sensory function, cardiovascular, and musculoskeletal. Put this whole package together to say, Mr. Jones, I think that if you had a transtibial amputation, I think you'll be able to walk, I think you'll need crutches, or whatever that potential outcome might be. Now, as a general rule, we know that the higher the level of amputation, the greater the likelihood of healing in this population, so you're going to heal more likely, but we also know that there's going to be reduced mobility and functional outcome. The lower the amputation, the higher the functional outcome, but definite challenges in terms of healing. So what I'm going to do here is to kind of go through a scenario, and maybe I can get a few of you to kind of help me out in terms of where your decisions would be. So this is your foot. It's not pretty, but it's yours. You're born with it. And now you're at risk of losing it. So you need to make some decisions here in conjunction with your surgeon. The rehab doc evaluates you and says, gee, if you have an above-the-knee amputation, I think you're going to be able to walk with a cane in your home. You'll probably be able to return home, but you won't have the endurance and the physical capacity to walk in the community. You'll need to use a manual wheelchair instead. If you have a below-the-knee amputation and you successfully heal this, you'll be able to walk independently in the home and in the community, and you won't need to use any canes or crutches. the risk is that if you fail to heal that below-the-knee amputation, if you choose that, you'll have to be revised to an above-the-knee amputation somewhere down the road, and it will require an additional 2 months of healing, and you'll end up where the above-knee amputation sort of was. So now, what you need to decide is what level of healing probability you would accept to undergo a below-the-knee amputation. So you know the differences in functional outcome, but what if the surgeon said to you, you have a 20% chance of healing a below-the-knee amputation? Would you go for it? Or would you say, gee, you know, I think I'll go for the above-the-knee amputation? Or if it's a 50% chance of healing a below-the-knee amputation? And this, of course, we can then create different combinations of scenarios where if you needed to have an additional surgical procedure, your operative mortality might be 0%, although if you're sick enough, maybe your operative mortality might be 5% or 10%. So how do you make these decisions are really, really challenging, but the important thing is that the decisions are unique to the individual. I've asked residents this kind of a question, and I've had residents tell me that if this was the scenario, even if it was a 10% chance of healing and it made such a difference in my functional outcome, I would go for that. Other people would say, you know, 10% operative mortality, I could die on the table with my second surgery, let's just do the above-knee amputation and let's move forward. But that's all based upon your own internal value system and your own internal priorities. It's just an example. Now, there actually are studies that have tried to tackle this, this question, not many of them, but there is one in particular where the question or the scenario was played out with healthcare workers on a vascular unit, and they were asked if they would prefer a BKA under certain criteria. And interestingly, they chose 20%. So if they had a 20% chance of healing a below-the-knee amputation, they would go for that, as opposed to have the functional decline of an 80% of a higher level amputation. Of course, every population is unique, and what we really need to do is to study this in a population who is affected by the process. The next thing I'd like to kind of sort of transition into is the idea of informed consent, because what we're really talking about is informing the patient about what their probable outcomes are to enable them to make better decisions about their health care. As the upper sort of comment here suggests, you know, historically informed consent was really sort of the idea of legalistic protection. So, gee, I told the patient, you know, there's a 5% chance they could get infected, there's a 4% chance they could die, and so it's okay, I told you, right? I told you so, so if it happens, it happens. But we're kind of moving away from that idea so that it's really, informed consent is much more a mechanism to try to facilitate a quality patient-physician interaction, the idea of shared decision-making. Reasonable people need to know their treatment options, their risks, benefits, and probable outcomes, and why the physician might recommend a certain treatment so that they can participate in the decision. Okay, we've had the amputation. Let's look forward to recovery. Now, early in the post-surgical phase, the rehab program is very intensive, focusing on muscle strength and endurance, cardiovascular endurance. We want to prevent contractures so that if a joint is kept in a certain position, it will stay in that position, and we want to make sure that there's a full range of motion. We have to enable independence and self-care and mobility even before the prosthesis is provided, and ensure that that patient is discharged to the right environment. We also want to prepare the residual limb to now be able to be fit inside of a prosthetic device. So we have to shape the residual limb, we have to reduce edema, protect the incision, and prevent contracture. At the transtibial level, or the below-the-knee amputation level, rigid dressings or casts are oftentimes applied to prevent the knee from getting stuck in a bent position, to help protect the wound and to ensure healing. So rigid dressings are one of the strategies that we use, but we also use elastic compressive devices, once again, to reduce swelling, shape the residual limb in anticipation of fitting with a prosthesis. So what about the prosthesis fitting side? Now, there are many, many different kinds of prosthetic devices. When we prescribe a prosthesis, the key components that we put together are what's called the prosthetic socket, which is this part, the sort of more rigid portion. We have an interface that is put onto the residual limb prior to being put into the rigid prosthetic socket. The limb needs to be held on in a certain way, and then of course we have a pylon that connects the socket to the prosthetic foot and the foot. So there are many, many different kinds of feet, suspension systems, sockets, and each one is most beneficial to a certain population. Along with the prosthesis, gait training is really critical. You can't just put a prosthesis on somebody, they have to learn how to use it. So now we've kind of gone through the process. So how well do we do? What is the outcome of the elderly dysvascular diabetic amputee? Well, as you can see here, the statistics are kind of a little bit awakening in terms of their significance. There's a 30% mortality within the first year after a major amputation. 2/3 of these patients will be re-hospitalized again. In those that had an amputation in the foot, there's a 20% probability of re-amputation, and there's a 14% chance you'll have an amputation on the other side. So these are kind of sobering statistics. Now, what about if we think about this more in a functional context? How well will people do? Can they walk? Will they return to functional ambulation? And what you can see here is that a significant portion don't ever walk again with a prosthetic limb, and in fact, a fairly sizable portion end up living in a nursing home. It's a really challenging population because of their underlying medical problems. Now, what about the idea of maintenance of function? So we want to continue the function in those that we have returned to function. I'm going to go back here for a second. Here you see that this schematic line is kind of drawn as a straight line. In reality, in this population, this is more like the shape of the line. There are medical readmissions, fluctuations in medical status that complicate the prosthetic fitting and the maintenance of function. So once you've got somebody to the point where they can use a prosthesis, it's challenging to keep them there and to keep their level of function. Now, before you all sort of walk away thinking, boy, this is really bad, I think to kind of put this in perspective, it's important to understand, how many people that actually have diabetes will kind of go through this cascade. And what you can see is that the prevalence of ulceration in those with diabetes is actually relatively small, somewhere in the 4 to 10%. So not all people with diabetes will undergo this scenario. And if you actually look at amputation rates in people with diabetes, they are relatively small in the 7 to 10% range over 14 years. So the majority of people with diabetes will not go through this cascade of events. But I wanted to kind of outline, this is our huge population. This is our sort of major challenge in rehabilitation. So at the start, I kind of addressed the sort of rhetorical question of, these high-performance amputees, and do they really represent the usual and typical scenario for our population with amputations? And some of you might ask, well, boy, this sounds like this would be kind of a depressing job, and the outcomes are sort of tenuous at best. But in reality, this is a really rewarding population to work with, because when you can return somebody to their premorbid level of function, however compromised that was, is hugely gratifying. So do they climb Mount Everest? No. But for them, climbing Mount Everest is simply going home. Can they do an Ironman? The answer is no. But there's a huge sort of sense of dignity that people have in being able to maintain their own personal care. And at the end, it's interesting talking to the older population. One of their greatest concerns is to not burden other family members with their care. And so the rehabilitation program of this patient population, in spite of its challenges, is hugely gratifying. So with that, I will close. So thank you.
It's my pleasure to introduce Daniel Abrahamson. He's prosthetic, orthotist, and rehabilitation medicine at the UW School of Medicine. Daniel is a lecturer, certified and licensed prosthetist in the Division of Prosthetics and Orthotics in the UW Rehabilitation Medicine Division. He's responsible for teaching the below-the-knee and above-knee prosthetic classes for the UW Prosthetics and Orthotics program and assisting with the instruction of the lower extremity orthotic classes. Daniel has specialized in the care of geriatric dysvascular amputees, and his research interests include study of emerging prosthetic technology. He earned his BS in psychology from Old Dominion University and a BS in prosthetics and orthotics from the University of Washington. He completed his residency in orthotics at Shriners Hospital for Children in Portland. His prosthetics residency was completed at the Center for Prosthetics and Orthotics in Seattle, Washington. Please welcome Daniel Abrahamson.
So the first thing that's really good to think about is what's been lost when you've had an amputation? What really is gone? I mean, clearly a limb is missing, but what does that mean? And so if we look here, there's different levels. At a hip disarticulation level, obviously more is lost at this level than at a knee disarticulation or a foot amputation or a transtibial right through the tibia or transfemoral. So when you lose a portion of your limb, you clearly have lost a power source. And that power source is what gives you mobility. And that's probably the first thing we think about. You know, you lose a leg, it now becomes challenging to walk. The next thing that often people don't think about is sensation. You lose sensation, you lose the ability to feel the ground. And so as I'm telling you this, I want you to think about, well, what can we return? How can we return things to people when they've lost a limb? You also lose proprioception. Proprioception is the sense to know where your limb is in space. When you close your eyes and you bend your knee or bend your hip, you have stretch receptors in the muscles, and those proprioceptors tell you where your limb is in space. You've probably all experienced the way we know where our limbs in space. Sometimes, you know, when you're walking downstairs and maybe it's a little dark and you think there's one more stair and you take a step and you stumble. We've all had that experience. And our proprioceptors tell us, oh yes, our knee is bent. The sensation tells us our foot is on the ground and you can catch yourself and you don't fall over. Now imagine walking with a prosthesis. You're missing that all of the time, so it becomes much more of a balancing act. Literally, it's like walking on stilts. And you've also lost a stable platform, something which anchors you through your bones to the ground. So it's really a tall order to replace that. So how do we go about replacing what we've been given, our natural equipment? And let me tell you, there is no way that we can really replace the natural equipment. What you come with is far better than anything that we can give you at this point, and I imagine probably several hundred years into the future. And that's being optimistic. Okay, so let me give you a little bit of an understanding of the anatomy of a prosthesis. So we start with the socket. There's the mouse. Okay, so this is the socket. You have a residual limb, right? We don't like the word stump, as Dr. Chernicki said already. That would be like a cut-off tree. So the residual limb goes into the socket and connects this mechanical prosthesis to the ground. And now this socket has to distribute the load over the limb that, like Dr. Smith said, was never meant to carry the load. When you look at this x-ray of a limb, to orient you a little bit, this is the femur, okay, the long thigh bone. This is the tibia, and sneaking behind here is a little piece of the fibula, the long thin bone on the outside of your leg. So this leg is really vulnerable and was never designed to bear weight. Our feet are designed to bear weight. Our feet are wide. They have a big fat pad on the bottom of them. They can absorb shock. Our shins, I'm sure at least a few of you have played soccer before, right? Where's my, I'm not sure if I have my slide in here of soccer, but we all know what it feels like to get kicked in the shins, right? That's our tibial crest. It's not a comfortable place to bear load. And so now we're asking you to walk inside of a hard piece of plastic, right? Like this, okay? And bear weight on that area where you've never borne weight before. So our goal as prosthetists is to try and make this interface this socket so that you don't bear weight on those areas where you can't and do bear weight on the small areas remaining where you can. So the spots that we want to avoid are really the distal end of the limb, down here, this crest or your shin bone, and this little bump here called the tibial tubercle where your patella tendon inserts into. That's a particularly vulnerable area. And then here on this x-ray you can see a little piece of the fibula sticking out. This bump, the fibular head, is quite uncomfortable, and the skin will break down if you bear weight over there. So how do we do this? How do we solve this problem of this fairly small little limb that wasn't designed to bear weight? Well, you look at this slide and you think, oh, you just go in the back and you grab one, right? That's not so hard. Clearly, everybody is different. We have here little limbs at the bottom right-hand side of the slide. We have long limbs. We have short limbs. We have scarred limbs. We have long, skinny limbs at the top and big, wide limbs at the bottom. So clearly these things are all custom-made to fit somebody. And now, that would be just fine if somebody's limb stayed that way, but how long does your body stay the same? Right? Sometimes you wake up in the mornings and your rings are a little tight. Maybe you had a little too much salty food to eat last night. Or maybe part of the etiology of your amputation is that you have a fluid transport problem. Maybe you have peripheral vascular disease. Maybe you have diabetes and your blood doesn't flow properly. Or maybe you just had an amputation 3 months ago and you've got a lot of swelling going on in your limb, and then that's going to shrink down over time. So there's lots of challenges. We create this static thing, a socket that somebody's limb goes into, and then your limb is dynamic and it changes. So that's a problem that we have to try and sort out. Some of the ways that we sort that out is by adding socks over the residual limb, which is sort of a very crude way of approaching this problem. As your limb shrinks, then we can add socks over it. Sometimes we just have to start over and make a whole nother prosthesis again. So, actually I'll stay on this slide for a second longer. So how do we make a prosthesis? Well, the way we do it is we have our patient's residual limb in front of us, and it's fairly crude. We take plaster bandage, we wrap it around somebody's limb, and take a cast of their limb. Not because anything is broken, but because we want to get an impression of that limb. And so we then remove that cast, and we have a negative image of somebody's limb. We'll then fill it full of plaster, and then take that cast off of it once the plaster's hard. And then we have a positive of somebody's limb. With that positive of somebody's limb, we'll then manually sculpt that and try and take the pressure off of that shin bone, the tibial crest, take the pressure off of the fibular head, take the pressure off of the distal end of the limb, and then try and load the areas of your bone where we can load. And if you look at the shape of a tibia, it sort of comes up and flares out to the side. We're very lucky because that's what we use. We use that flare of the tibia mostly to bear the load. Then, when we've got that nice positive shape that we've sculpted, we then will pull plastic over it. We'll have a big sheet of plastic, put it in the oven, make it really hot, and vacuum form it over this shape that we've created. Then remove that positive shape. Unfortunately, with a chisel and a hammer, we sit there and pound it out. So it's manually quite intensive. And then we create what's called a test socket, which is something that we can visually see through. We'll put this on our patient's residual limb, often with a pylon. This is a pylon or a pipe, and a prosthetic foot attached to it. Then we'll go through the process of having somebody walk with it, and we'll heat and change this and make adjustments to this dynamic shape so that it can fit just right for the moment. So it's a lot of fun. It's a mix of art and science for sure. There's no one right way to create a prosthesis. There's design principles that we all follow, but a lot of creating this socket is artistry. Grab another demo model over here. So then we've spent quite a few hours getting this socket just right. It's fitting somebody. We then attach it to a prosthetic foot with something called a pylon, which is a pipe. Because when you have this socket in your hands, you don't exactly know where the foot goes. It seems like it would be a simple problem, you know, the foot goes right underneath where the leg was. But unfortunately, it's not quite that simple. There's small changes in how you position the socket over the foot can affect how you walk. And you've all probably experienced that when you put on shoes with a little bit of a higher heel. It tosses your center of mass or your position of gravity more forward, and you have to readjust by bending your ankles. Well, now, if you can't bend your ankle anymore and the socket's not in the right place, it makes you feel like you want to fall over forward or fall over backwards. Or it can feel like on one side of your leg, if it's not just right, like you're walking down a hill all the time on one side, and then you're just walking on flat ground, or you're walking up a hill, or if the foot is a little too much out to the side, it can make you feel like you're falling to the right or to the left. And then as you become stronger, you might move your feet closer together, and so we need to accommodate and change the prosthesis and move it a little closer together. Then there's the thing that a lot of people hear about on TV, which is the prosthetic foot, because it's very interesting and intriguing to look at. People always ask me, you know, when I'm stuck in the airport like I was this past weekend, so tell me about technology. Prosthetic technology, it's really great, isn't it? And then I hear all these things about technology, and there's a lot of misconceptions that are out there. Technology is wonderful. A lot of nice things have happened in the past 50 years with prosthetic technology. But again, it's still, from a global perspective, still quite crude. Let me show you this prosthetic foot, which probably 50 years ago was all the rage. It has got a single axis mechanism inside of it, which allows the foot to move up and down. Okay, but it doesn't move up and down on its own, right? There's no power source here that we've lost, no batteries, no battery pack. Matter of fact, they don't make any feet. Feet are not made that move up and down on their own and actually propel you forward. There is, just in the past 6 months, a foot that came out that will move up when you want to clear a step or go up, but it doesn't actually move up and then push you forward. So this foot has a little axis, and when you lean on the heel, maybe I'll put it up here where you can all see. You lean on the heel, it moves down, and when you go over the toe, it bends a little bit. Pretty simple mechanism. What that does is when your heel strikes the ground, it stops your knee from being thrust forward. Okay? Because if this was a solid ankle, it would be very similar to walking with a ski boot in the ski lodge. Maybe some of you experienced that. You feel like you're walking like this and your knee gets thrust forward. So this is a way to accommodate that natural ankle motion that we all have, that when our heel strikes the ground, our foot plantar flexes or points down. Then, probably about 15 years ago, people designed some very interesting feet. And we like to steal things from different industries. So from the aircraft industry, we stole carbon fiber. And in this foot is a much more ingenious way of simulating that normal function of the heel going down and the toe coming forward. It's a carbon spring. And now the nice thing about a spring is when you compress a spring, what happens? It then springs back, right? So as opposed to those shock absorbers, right? That's got little elastomers, which are shock absorbers. And when you compress a shock absorber, its goal is to like slowly rebound. And so now we start using carbon springs, and carbon's what? It's light, and it's very durable, it's very strong. So we have these carbon springs that when we compress the heel, if I can do this, I'll compress the toe and show you. There you go. It takes a fair bit of weight. This spring then kicks forward and pushes you forward. You know, that's neat. But it's not that neat if you're missing a leg. What you really would like is something that would help you to walk and make you move forward. So you've lost that power source, and we don't really have something to replace it with. So, when I hear the comments about, isn't technology great? And I just think, it is wonderful, and it has come a long way, but it's got a long way to go before it's really wonderful. Let's see what's next. Then we have knees. You hear a lot about knees also in the media. Let me tell you that most prosthetic knees are just a passive hinge. They just bend. And you have to use your remaining residual limb and all the force there to straighten that knee and to bend it as you walk. So as you walk with a prosthetic knee, this just, it bends when you're getting ready to swing it, and then you kick it forward and it straightens. Okay? I cannot let go of this and have it walk across the room. Right? It won't do that. And so what technology has done for us is take this passive hinge. This has got a little spring on it that kicks it forward. Right? We like springs. Springs are nice. And a little hinge that bends. Not very sophisticated. To a very sophisticated knee that came out, let me say 6 or 7 years ago. Okay, called the C-leg. You see that very often. Okay, so this is a very sophisticated pendulum. And you think, pendulum? Haven't they been around for a very long time? Yes. Okay, so this pendulum is now modulated by a microprocessor which adjusts how fast this swings, which actually is a huge advantage if you have to wear a prosthesis. It means that when you want to walk at more than one speed, then the heel swings at a modulated rate by a microprocessor, so that if you were walking with that old pendulum or that old hinge, when you walked faster, your heel would kick up really hard, and then your leg wouldn't be straight when you wanted it to be. So this very sophisticated passive hinge now modulates that swing. And then it does one other thing that is very, very important. Okay, when you stand on this knee with your heel on the ground, the last thing you want it to do is to bend, right? Because this is a hinge. So if you go to put your weight on your knee and it bends, then what happens? You fall down, right? And who wants to fall down? Like every time you take a step? Nobody. Who even wants to fall down once a week, right? I mean, it's okay, you can fall down once a week. So this huge advantage is that you now don't have to worry so much about falling down, because the microprocessor inside this knee says, okay, there's weight on the heel. That must mean you're getting ready to step on this. Okay, so we're not going to let the knee bend. Or there's weight on the toe. The knee is straight all the way. These little load sensors sense that. Time to get ready to swing. Okay, so let it bend. It is very sophisticated, but again, in my opinion, I mean, if people talk about technology and how wonderful it is, not nearly as good as the original manufacturer's equipment. That is for sure. And so then there's cost. Anybody want to take a whack at not all the stuff that I make or the foot that we buy, but what just this knee costs? 15? Yeah, you guys are, 50. Oh yeah, it's not, unfortunately it's not that much. No, but it's about $17,000 to $20,000 for this knee, which is a lot of money for a microprocessor modulated pendulum. And then it runs on batteries. And so they last, they last about 2 days, but if you want to go hiking out in the Cascades, you have to plug it in and have it charged. So it's definitely got its downside. And in Seattle, if you spill your latte in the top, it's a trip to the shop that costs quite a bit to have it fixed. So let's talk a little bit more quickly about technology. Okay, so very excited about this new development that has just come out. Till I actually saw it, but I'll tell you more about that later. This is called the Power Knee. It is the first prosthetic component that actually has its own power source that will actually move you through space. And it's called the Power Knee, hence, and it is an active hinge. Now, I thought this is going to be wonderful and revolutionize prosthetics, and it probably will, but it's still really an R&D at this stage. There's a few people who wear this knee. It will push them forward. The first thing that you probably notice is the thing that I haven't even talked about, right? That at the bottom it costs $56,000, and guess what? That's my cost. So that won't be your cost if you need one of these. It weighs 10 pounds, which is incredibly heavy. It's very noisy, and its battery lasts for 5 hours before you have to recharge it. But you know, I think all those things are going to get worked out. The really hard part that is going to take a little while to work out with this knee before it's really ready for market on a mass scale is the software that lets you, as the user, tell that knee when to give you power. For example, you're walking upstairs. This knee is pushing you upstairs. Now, your cat's in front of you. The knee does not see your cat and keeps wanting to push you upstairs, and you're stopping with the other side. And so then you're in a quandary, and you might end up at the bottom of the stairs again if you're not careful. And then you come back to the same problem of the basic function of a prosthesis with a knee is to not let you fall. Or somebody's in front of you and you have to turn, and the prosthesis wants to go straight. It can be a real problem. So my analogy is that it's very much like dancing with a robot. Okay, you have to learn how to dance with this robot. And as the software improves, it will become much better. So I'm very hopeful about this new development. But it's currently not definitely what I would consider perfect. So in summary, you would think, based on what I said, that we probably don't do a very good job of helping people walk. But the reality is that when you watch somebody walk, it's amazing how well people can walk with an amputation where they're missing that much limb, when really the prosthesis that we provide doesn't even come close to meeting the needs of the original manufacturer's equipment, I'll call it. You can see that this individual first is an incredibly good walker. By that we mean that he is really an athlete who has worked really hard to walk well, and he's also young and healthy and all the things that we love about our patients that make things easy for us. And so for him, we don't really have to do that much. You just give him a prosthesis and he walks fairly well anyway. So there you go. That's somebody walking with a prosthesis. So what I would like to say in summary is that it's not, when you hear about amazing technology, it's not amazing technology. It's this guy. He's amazing. I mean, I've got 2 legs. I would not drop off that wall with my bicycle, okay? I mean, nothing attached to him that I do or anybody can do for technology will make this person more amazing than he already is. He is down now in South America competing for Red Bull, riding his bicycle through the streets of Chile, Santiago, and dropping off cliffs and doing crazy things like that. And that's not his prosthesis. That's not technology. That's an amazing individual. And so that's what I want to leave you with. All these people that we see, they have amazing spirit. They want to thrive. And they thrive because they're amazing, not because we're amazing. Maybe, as Doug said, we're coaches. We try and help people along.